There's no shortcut to a health span. You cannot just get an injection or run a fancy treatment and then live forever.
Half of the people I see are patients diagnosed with medical condition. Therapy was designed for him to lifestyle interventions to manage to reduce his A1C from 7.2% to 5.4 and get him off insulin. He lost 17 more kilograms. His BMI, initially 36, is now 27.
As far as I know, absolutely no scientific evidence that any supplement is a longevity supplement.
My mission is to safeguard people from supplements. Is take them off.
Why is it a problem?
You have no clue about the interaction of these substances.
The term longevity has challenges. It covers a whole range of medicine, from evidence-based to snake oil salespersons. We're selling stuff that just doesn't work.
My guess that a majority of men would benefit from some sort of testosterone therapy.
The most important thing that's lacking in the whole field, the scientific rigor, people are just trying to, it's like activism, trying to do stuff and see if it's helping, but we never rule out the placebo effects. Obviously, something has to change in healthcare.
Hey everyone, welcome to the Optispan podcast. I'm super excited to be here in Berlin at the YEARS Clinic with Alexandru Ardelian and Jan Hennigs. Jan is the medical director of YEARS, and Alexandru is the lead physician here at the Berlin Clinic. So we're going to dive into all sorts of topics, but I thought it would be good just to get a little bit of background on each of you and how you ended up here at the YEARS Clinic. So why don't you go ahead and start?
Of course, yeah, thanks. So we're happy to be on your podcast. We're really stoked that you're here in Berlin, visit us in our clinic. So I'm a physician and a molecular biologist by training. Spent most of my time in academia, almost 20 years. I'm an expert, specialist in internal medicine and pulmonary medicine. And most of my time was basically on a clear academic track. But with recent years, it occurred to me that, especially being in a respiratory in a university medical center, we're seeing patients with very progressive disease that came in very late, and most of these diseases were preventable. It occurred to me that we basically should switch things around and prevent these diseases from happening. And then, given the financial constraints and even the strain on the healthcare systems that we're having with the demographic changes that we're seeing, it became obvious that the healthcare system that we're seeing today doesn't last, and we have to change something. And that was the idea behind YEARS. YEARS has two missions. One is to be a scientific health span clinic, to bring evidence-based preventive medicine to the people, to make it appealing, to change something there, to really get from a reactive healthcare system to a proactive healthcare system. And the other mission, the bigger mission that we have, is basically research. So we really want to help finding out what is causing aging, what are the molecular causes of aging, and discover new biomarkers, discover new interventions, and be a scientific platform for that.
Great. A couple things I want to do a little bit deeper dive on, but let's have Alex introduce himself as well.
So I'm a board-certified specialist for internal medicine. I had a non-academic track. I was actually on the classical course of the clinic environment. Started my training as an internal medicine specialist, 2012. And I can tell you the exact night when I had this mind shift. It was in 2018 in November. I was doing my 24-hour shifts in the emergency department because back then it was standard to work 24 hours plus. Yeah. And I was reading actually the Why We Sleep of Matthew Walker, and I realized I'm kind of slowly committing suicide with those 24-hour shifts. And it was through that literature that I discovered the lifespan of David Sinclair, and actually that's where I first read your name. Yeah, and it was clear to me that something's really off, because I kept seeing the same patients over and over again in the in the emergency department with their decompensated heart failures, and I asked myself, but when did it actually begin? What are we missing here? Because I'm pretty sure they didn't wake up one morning heart insufficient, and then it was like a progression from the acute healthcare system into the preventive one, and by chance, and maybe not just chance, I got to have a great discussion with Jan, and actually I was looking for a place where I could practice a high quality of medicine, basically, because I'm pretty sure we're gonna dive deeper into that subject. What is longevity, and from my side is definitely first and foremost high quality medicine.
Great. So when did you guys start YEARS? How long have you been in operation?
So the first clinic here is open since October 2024.
Okay.
But before that, we had an almost 2-year period of planning and setting up all the SOPs and the procedures and the infrastructure.
Right. Well, it's a beautiful space. I'm looking forward to touring it. And then I understand tomorrow I'm going to actually go through the program, which will be exciting. So you used the phrase, I think, scientific healthspan medicine, and I'm interested to understand why that phrase as opposed to longevity medicine, which is, what I think most people would immediately assume that YEARS is.
I think with the term longevity is a little problematic because it's not very clear right now, because it covers a whole spectrum of high-class medicine on the one end of the spectrum. And on the other end of the spectrum, we have snake oil salespersons who are really selling stuff that obviously doesn't work, but people fall for it. So that's a challenge we have in the field of longevity medicine, basically.
Yeah.
And on the other hand, longevity is probably not the correct term as a scientist, because it's the lifespan of an organism and not the health span. So we really want to have more healthy years and not just a longer life suffering, because that is what reparative medicine has achieved, basically.
Yeah. I know it's funny because people, I've been studying the biology of aging for 20 plus years, and one of the things people immediately who aren't in the field or familiar think about is, well, I don't want to live longer if I'm not healthier. And I'm like, no, that's not what happens when you slow aging. It's the opposite, right? You live healthier and longer. Reactive disease care has been successful at making people live longer without being healthier. So that's really what we've done in most developed nations over the last 50 years or so.
Absolutely. No, absolutely. That's the point. And the other part is with a scientific health span. So we really planned the whole place like a clinical study. Mm-hmm. So we thought, okay, so we went out and went, so we want to really participate to understanding the biology of aging, to really make a dent, to really be able to understand where we can intervene earlier, and really identify risk early, to really be fast and really shift things in healthcare around, to be proactive, preemptive. So that's why we use the term scientific.
So Alex, what am I going to be in for tomorrow when I go through the program?
So, Matt, you're in for a broad array of different tests, spanning from functional metrics. We will do our best to measure your strength. We use grip strength. We use counter jump movement as a proxy parameter for the lower extremities power. We use different methods to assess your balance and your flexibility. So basically, actually, I think we can spread it into two categories. We use a lot of clinically standardized tests, spanning from a whole battery of sonographical diagnostic, from abdominal sonography, echocardiography, screening of the neck vessels, and analysis of the thyroid gland, biochemical biomarkers, basically. We have a full body plethysmograph because Jan is a lung expert, so we don't just ask people to blow in the tube. We lock them up in a cabin.
That's true. We do that. Yeah, we do that. Yeah, exactly.
Well,
It's a sealed cabin, but you can wave.
We have an analysis of the sensorium. We do an audiogram. We will check your visual system. But we also do experimental analysis, like a full body MRI, which is not the typical one. It's a YEARS proprietary sequence, which merges basically highly focused individual sequences into a full body MRI.
And so is that, I mean, is in a general sense, does that just mean it's higher resolution than a typical full body MRI?
And those are the clinically used sequences that we fuse to form a whole body MRI from head to knee, basically.
Got it. Okay.
There's also experimental tests like liquid biopsy for cancer detection.
And is that similar to the Gallery test by Grail, at least technology-wise?
So we're using a test that's looking for circulating tumor cells because the Grail test is not available in the EU yet.
Okay. So it actually looks for cells as opposed to methylated DNA sequences. Okay.
Exactly. So and the specificity is quite high. Sensitivity is rather low.
Okay.
Especially, I mean, it's not an early cancer detection test, so the strength lies in the larger stages, later stages of cancers for all those tests to be fair.
Got it.
That's what I also try to make clear to our patients, that is not an early cancer detection test battery, because if it looks for circulating tumor cells, if the tumor doesn't really have connect to a blood vessel, then it will probably miss it. So, yeah.
And so I am going to show up at 8 a.m. tomorrow. How long does it last?
The program you're in for, I would say 6 hours.
6 hours.
Okay. Without the MRI.
Without the MRI. Okay. And when does is that at the beginning or the end or?
At the end.
Okay. And I assume I show up fasted, so I should not eat. So are you guys going to feed me?
So we're going to feed you in between, exactly,
because I get hangry.
You have to do the CPAP. You have to do the cardiopulmonary exercise test.
Okay.
So we really want to measure your VO2 max.
Sure.
It's a VO2 peak to be very specific, but then you need to eat before you do that.
Okay.
Otherwise, we'll be tough. We take
that's probably not a fair VO2 max assessment.
So, but we want to get the oral glucose tolerance test. So we want to see if you
Oh, you do a full OGTT?
We do a full OGTT, exactly.
Okay. Interesting.
And that's why you need to be fasted for at least 12 hours.
Sure.
Before you shower.
Got it. Okay.
You were kind of surprised that we do a full OGTT test?
Yeah. I mean, I guess I wasn't expecting that, but great. I've never had I've worn a continuous glucose monitor many times, but I've never actually done the clinical OGTT. So that'll be interesting.
Well, there is data that suggests that if the 1 hour glucose is above a certain threshold with like a delayed pancreatic response, it is predictive of the type 2 diabetes risk. So I find it a very valuable test. We also combine it with the HOMA insulin resistance metrics. So actually, in the assessment of the of the metabolical state of a patient of ours, we use a multi-metric assessment to kind of detail the risk.
And when you said biochemical parameters, you meant comprehensive blood work. Basically, it's going to look at glucose, insulin, lipids, maybe inflammatory markers. What, in a general sense, what's in there? Hormones, I would guess.
Exactly, hormones are in there. So we're looking into all the organ-specific biomarkers, liver panels, kidney function, of course. You're getting the whole blood work, and for including FACS analysis of the immune status, immunophenotyping we're going to do. So we've got a full sex hormone panel in there. We've got all the metabolic hormones that is associated with risk, leptin, adiponectin, of course the glucose metabolism, and Yeah, so it's really, I mean, I think we have 270 parameters. We also have GDF15 included as an experimental parameter.
Interesting. So you have you kind of again break it down between well-established clinical biomarkers and more experimental data collection kind of biomarkers.
So we have three different approaches. So everyone gets these three different programs. Everyone gets the same clinical workup, basically highly structured, head to toe, as I mentioned before, and then the experimental aspects are what differentiates the different programs: liquid biopsy, MRI, epigenetics. We do that as a research approach.
Do you report a biological age score
We
based on epigenetics?
We do, but this is only this is research only. We also report other biological ages that have been validated in large cohorts, but we never base any recommendations on those biological age because they are not specific enough. We don't know how they react to specific interventions.
Yeah. And do you do the methylation analysis in-house, or do you have a...
So we have a partner who's running the methylation for us, the methylation analysis for us.
They're doing the methylation analysis and the computational part, or the laboratory part. Okay. Yeah. So they do the laboratory processing. I mean, I don't know how much you guys are following this, but I've been quite vocal about my concerns on the direct-to-consumer side, right, with the methylation test, because we don't really know what the error rate is just on the laboratory.
Exactly.
Right. So it makes it hard to understand, even as a research tool, it makes it hard to understand what it means if we don't know the error on the
absolutely
the laboratory component.
So yeah, we don't. So that's something we discussed with our partners in genetics and epigenetics as well, because they from a clinical geneticist standpoint, they'll tell us that they don't know how to set the cutoff. So
interesting.
So how many standard deviations should we account into where this becomes a valid result,
right,
for in a clinical setting,
right?
And that's the same problem we're struggling with. So we're really just gathering this data as one of the biomarkers. We tend not to over-interpret any of the results, because we're not basing any medical recommendations on these parameters of any of the ages.
And do you do any of the organ-specific methylation algorithms now?
Not yet, but we try to implement this just for the sake of research, because we want to understand how this reacts, especially how this reacts to interventions, because there's very, very little data on how these clocks respond to.
Oh, I agree. Yeah, but I one of the reasons why I'm a little bit more bullish about the organ-specific epigenetic clocks is because I think you could potentially use it as a screening tool, rather than trying to use it as a diagnostic or give a number. But if it can give you an indication that there may be something bad happening in a specific organ or tissue, then you can go do further, more targeted diagnostics. It's kind of like a multi-cancer detection, where you can maybe from the blood determine there's a signal for a particular type of cancer, and then you go do a follow-up to confirm or refute that.
Absolutely. So that's how I understand these clocks, the epigenetic clocks. So they are risk models. And they screen for,
right, but if the risk is mortality, that's not all that helpful.
Exactly, that's the point. So if it's overall mortality, that is a bit of a problem, right? So it's highly unspecific,
right?
But at least for a clinician, it's the hardest outcome that you can measure, mortality. And then if you look into morbidity, but you really want to understand what causes, what's your risk for a certain age-related disease, right? And this is something that most of these clocks don't really.
Yeah, and again, there's the precision piece, which is a laboratory artifact almost, if there's a lot of error. And then there's the accuracy piece. And I just don't think we know enough about either of those at this point.
I fully agree.
But you're biobanking samples as well, right? And then are you running the omics now? Metabolome, epigenome? Do you do microbiome?
So we do the microbiome. We do gut microbiome. We're also thinking of having the vaginome included into our program, also for research purposes. Because there's hardly anything you can do with that, to be honest.
Do you do anything with the microbiome? Do you make recommendations based on that, or is it purely research at this point?
To be honest, the recommendations you can pull out of the microbiome are, what's evidence-based, and we say evidence-based. What we use here is level 2 and above. So there should be randomized controlled trials, so that we can really recommend anything from that. There is, it's mostly descriptive, right? What we have, and that is the biggest problem with microbiome. So, you should eat fermented food,
right? Get lots of fiber.
Get lots of fiber, exactly. And then, I mean, there's some interesting data regarding type 2 diabetes.
Yes, I sometimes see the association between pre-diabetes and lack of Akkermansia species or butyric acid producing species. And there is data to suggest that if you try to repopulate with those strains, the glucose metabolism improves.
Right. Yeah, I've heard the data on Akkermansia. Do you recommend then Akkermansia?
We quantified in the microbiome analysis. There's a specific quantified analysis of the Akkermansia, and if it's like below the threshold, the measurable threshold, then I usually recommend supplementing with the probiotic. But there is, to be fair, only one producer.
Right. The pendulum, right?
Yeah. Because they do the living strains.
Right.
So there's a lot of people who, companies who offer the non-living strains, but there's no data to support that they work.
Right. Got it. And then metabolome and transcriptome.
So what we're doing is we have our lab here where we process, or we in biobank 80 samples per patient, blood, urine. We also got a urine analysis, clinical validated urine analysis, of course, tomorrow. Stool, we isolate DNA and RNA, but we're not doing it. We're not running it right now, so we're doing it in batches. So once we have hit a certain threshold, we can do the bulk analysis and actually draw meaningful insights from that. So we try. We're in talks with a large metabolome provider to implement their strategy as well, so that we can run metabolomes right away. But that's nothing we're offering as of now.
Got it. And then do you do anything with oral health?
So that is actually, we have a dentist next door. That's something we need to implement because it's such an important aspect of health span.
Yeah.
We know all the association, periodontal health and cardiovascular risk, for instance. Right. So,
and diabetes as well.
Diabetes as well.
Yeah. Cool. Well, I'm looking forward to it. It's going to be an experience. So I noticed that you used the phrase scientific health span when you describe what YEARS does as opposed to longevity medicine. And I'm wondering why.
I think it's an important question. So the term longevity has two challenges, I think. One is that it covers a whole range of medicine or longevity medicine, from evidence-based, highly specific, high class medicine to snake oil salespersons who are selling stuff that just doesn't work, right? So that is one of the major problems. The other aspect is that, at least from a scientific point of view, it's not the right term. Because longevity means lifespan of an organism, and we're really interested in the health span, because with the reparative medicine, we've been able to prolong the lifespan, but we haven't been able to prolong the health span over the last 30, 40 years.
Right. If anything, it's gotten worse because there are a lot more people who live longer with chronic disease, at least from that perspective.
True. Yeah. So that these are major problems. So that's why we call it a health span clinic. And the scientific part of it is that we looked into the landscape that's out there. We went through all the scientific populations that are available to understand the biology of aging, to really understand risk factors, to see if we can model risk better and find intervention, because that's our main mission basically here with YEARS. And we found that the data is quite heterogeneous. It's not verified. So it's really hard to combine these data and make a lot of sense out of it. I mean, Big Pharma has tried it and they failed. So that's why we decided to basically set it up ourselves. We set the whole system up as a prospective study. So we have a highly structured approach. Every patient gets the same clinical phenotyping from head to toe. And then we combine this with integrative multiomics, where we ask all our patients and clients to donate their data and biospecimens to our research platform. And then we process these samples right in the research lab, right on premise.
Wow. That's pretty unique to have a research lab on the same location as a clinical program.
Yeah, so we thought that would be something that's really missing in the organization, because there are a lot of longevity clinics and clinics that are gathering data, but it's rather unstructured, and it's not made for sharing. That's exactly what we want to have the metadata. We want to have it shareable. We want to contribute to the community, scientific community, to really help understanding the biology of aging.
So let's talk about that. So what are your thoughts or your intentions in terms of being able to make the data accessible? Will, say, academics be able to get access to the data set, and at what point do you envision that happening?
Okay, so the way we envision the data set growing, I mean, we've just started gathering data, but what we see is 70% of our patient clients agree to donate their data to science, which I think is coming from an academic background quite high. So we have basically three pillars of growing the data platform. One is our own clinics, where we can basically control all the processes, have a higher standard of the data gathering, and then we would like to enrich it with partner institutions for certain indications, for instance, if need be, or for validation, if we have discovered a new risk signature, for instance. And the third pillar is academic collaborations, to share data, to try it on new technologies, to integrate new technologies in our data set. And this should be really open to industry and academy.
Cool. Yeah, I think that's a fantastic initiative. So are you guys doing anything with wearables or trackables at this point?
So the way we have them integrated now, of course, everyone can upload their data before they actually can upload your data if you're into that. We can share the safe link with you, so that we can have a look into the data that you share with us. The way we have it integrated as of now is that we work with coaches in the end, because lifestyle interventions are still
And I want to talk about interventions for sure. Yeah. So
most meaningful intervention that we can have in healthspan medicine. Those coaches usually use wearables to track success, CGM, Oura rings, for instance, sleep tracking. We're of course activity. We're currently building a platform where we have this integrated as well in an app, so that you can track it yourself, integrated with our data and some risk scores there. So we're not where we want to be as of now, but we're on the way, and we're using it.
And do you employ coaches then as part of the program?
So this is a partnership. So we basically screen them, and then we set up a set of rules. And then we recommend these coaches. So they're not employed with us.
I see.
They're self-employed, but they're part of our.
So clients can have the
universe.
choice whether or not they want to engage. But you sort of vet them a little bit.
Exactly. Okay. So we vet them so that we make sure that they are also evidence-based. We make sure that they're really following our strategy and are integrated in our intervention strategy as well.
Got it. So let's talk about interventions. So you get all this data on somebody, and then what do you do with it? Right, in terms of what you recommend back to the patient?
I think the easiest answer would be we build risk profiles and try to I can best answer this from my day-to-day practice. I try to prioritize where the greatest return on investment would be. So, for example, if your grip strength would be at the 92nd percentile, I'm not gonna go for the 3% increment there. But if there is a certain signal for faulty glucose metabolism, I would definitely go way deeper into that direction with specific nutrition recommendations, aerobic training, strength training for just for the sake of increasing the insulin sensitivity, for example. Or I would think to go back on the question, what is longevity? Well, one of my problems with the terminology is that it has the question is, what does a person visualize when they think about longevity? And they pretty much, in my opinion, see a healthy individual who just wants to stay healthy and be highly functioning. But half of the people I see are patients diagnosed with medical conditions. So, for example, I had a patient who's typical type 2 diabetes. He's just 54 years of age. He has had really bad cards. So, but based on very specific recommendations from a complete change in the way the therapy was designed for him through to lifestyle interventions, basically we managed to reduce his A1C from 7.2% to 5.4 and get him off insulin.
Yeah.
So that's not something people envision by longevity. Basically, this is layer 3 of prevention.
Sure.
So it has, you have primary, secondary, and tertiary prevention. And I think people think about just the primary prevention when they hear the term longevity. But I'm pretty sure we want quality and quantity of life for the patient who is now formally non-diabetic anymore.
Right. Yeah. I mean, I agree completely. I think, the way I think about it is when you first see a patient, you want to get sort of the baseline data, which is that large data set. And then some people have conditions that need to be acted on right away. And you act on them right away. And sometimes that's even reactive disease care, right?
Yeah.
If somebody has cancer and you find it, you take care of the cancer. Diabetes is interesting because you can actually reverse it in many people. And I mean, it's sort of an arbitrary definition of when we define somebody as diabetic, but not in everyone, but in many people, you can actually bring them back into the pre-diabetic or normal range. And as you alluded to at the beginning, that's the lowest hanging fruit for that person. That's where you're going to get the biggest bang for the buck. So you start there. You mentioned lifestyle in this individual. I'm assuming there was also prescription medications involved. Yeah.
Actually, there was a reduction in the prescription medication he got, because my target there was to somehow get him off insulin.
Yeah, right.
In my clinical experience, once you get on insulin, it's kind of hard to get off without lifestyle interventions. And the tendency is to just increase the dose and do HB1C cosmetics, basically. Right. And not target the insulin resistance part.
Right, exactly.
But with a lot of work from the patient side and the guidance from our side, he managed.
Yeah, so let's dive into this, because I think a lot of people watching may not, maybe they appreciate that diabetes is often reversible, but may not know how to go about it. So in this case, and again, it's not going to be the same for everyone, but I think there's probably some underlying similarities. Like what did you do?
So just a quick summary of the case. The patient was basically not doing any type of sports, eating kind of wildly, not taking care of any specific dietary patterns there.
So sedentary, poor diet.
Sedentary, poor diet.
Not uncommon.
Obese.
Yeah.
Was kind of expected. And just relying on the medication. To manage the disease. Had also concurrent risk factors, hypertension in quadruple therapy back then, and so actually formerly therapy-resistant hypertension by definition, and was on a triple anti-diabetic therapy, insulin plus oral, and Mounjaro, like tirzapartide.
So already on the
GLP-1.
But
GLP-1
it was interesting
agonist.
because his weight was plateauing. He experienced a weight loss, like I think it was 12 kilograms when he started the GLP-1 GIP agonists, and then it was plateauing because there were no lifestyle interventions, and nobody was addressing the insulin resistance.
So really just relying on the medication.
Yeah, but exactly. So basically, what we did there was we suggested he was starting a true insulin sensitizer, pioglitazone, and then slowly reduce the insulin while doing aerobic training. He basically went from 0 hours a week to doing religiously 5 hours a week, incrementally, of course.
And this is all aerobic training, or was there also resistance?
Initially, just aerobic, because I thought that would be the most effective intervention to get him into doing sports again. Now he's also doing resistance training, of course, twice a week. He's really good at it.
Yeah, great.
And he reported, I had a discussion with him on Friday. We have to further reduce the blood pressure medication because he's now kind of borderline hypotensive, going from 4 to 2 and now reducing them even further. And he lost 17 more kilograms. His BMI, initially 36, is now 27.
And were there any dietary modifications in terms of quality of diet?
For sure, no refined sugars. He increased the fiber up to 40 grams. He's doing 30 to 40 grams a day. He's eating twice a day plus a snack. He's kind of doing time restricted feeding, but it's just because his lifestyle pattern dictates it more or less. And we also increased his protein intake because he was kind of going on 1 gram per kilogram of lean body mass. And when he started resistance training, he increased that to 1.4, 1.6-ish. And he's basically eating a lot of vegetables, which he didn't used to do.
Seems like a general strategy for a good diet, right?
Yeah.
What I like about this case is that it basically nicely showcases the approach.
Yeah.
Because you have we want to do actual real medicine here, right? And so you have the pharmacotherapy that's needed in the beginning, but you really need to implement the lifestyle changes.
Yeah.
Because they are still the biggest sort of intervention that we can have with the highest effect size.
Yeah.
And then combine it and then personalize the approach, because you really need to find a way to have a targeted, goal-oriented therapy for each individual. You cannot recommend the same strategy to everybody, and then it works. And this is really something that really want to show on a population basis.
Yeah, I mean, I think these case reports are very, very powerful. I mean, I've seen the same kinds of outcomes with several of our clients at Optispan, and I mean, that's one of the things that's nice is, I mean, I feel like there are a small number of groups that are very mission, vision aligned and approach aligned, and always it's going to be evidence-based. For like us and you guys, starts with the science, it starts with the evidence-based data collection and analysis. And it's always going to start with lifestyle. It has to, because that's the most effective way to positively impact people's health and prevent disease. And then you layer on top of that the pharmaceuticals. I want to talk a little bit about supplements and get your thoughts there. And then, of course, for people who have pre-existing conditions, you need to sometimes do the reactive disease care to get them to a stabilized position where then they can benefit from the other aspects of the programs. So let's talk about supplements. Do you guys, I mean, we talked about akkermansia. So sometimes for some people, akkermansia might be a recommendation. Do you have go-to supplements that you feel there's enough evidence to recommend them for everyone? Well, no, I wouldn't. Yeah, I mean, you tell me. Is there anything that you recommend for everyone? But I mean, just in general, are there some that you feel that for certain people, you do it commonly? Maybe is the way I would say it.
So, I mean, we don't recommend supplements like on a blanket basis for everyone. So
Sure.
It's part of the discussions that we have with a patient for a personalized program, but we really want to understand the risk factors and we want to understand the effect of the supplement. So we really, and the same we apply to the supplements. We use them as a pharmaceutical as well. So if there's enough evidence to recommend them in a certain situation, then yes, we would do that.
Sure.
If a person really wants to try out a supplement, for instance, to lower their blood pressure, we had this case, patient who said, okay, I don't want to take a blood pressure medication. I really want to try arginine first. Then we came up and we of course, we went through literature and recommended him a dose of arginine and said, okay, this is a test run. So you get this for 6 weeks. If it doesn't change anything, you come back and then you get the antihypertensive medication.
Yeah.
He tried it. It didn't work that well. He came back and then he was on antihypertensive medication. But that's the way we approach it. And maybe you can add on that.
Yeah, I would add sometimes my mission is to safeguard people from supplements, to just take them off supplements.
People come in who are taking 30, 40 supplements.
Exactly. Yeah, and with elevated liver enzymes and pancreatic lipase
so maybe just state explicitly. I know what you mean by that, but why is it a problem sometimes to take 30 or 40 supplements?
I think first of all, because you have no clue about the interaction of these substances. The dosage is kind of shady most of the times. Since there is no scientifically backed recommendation for a specific indication, the dosage is kind of there's this German term is thrown out of the hip. So it's just basically invented by either friends, patients,
supplement companies.
Supplement companies, exactly. I think the number one would be there's no way to make statements about the interactions and possible dangers.
Yeah. And you mentioned liver enzymes. I mean, I think that's one of the things you tell me how, I mean, it sounds like you see this periodically, but when you're taking all of these things, first of all, your liver has to metabolize many of the supplement active ingredients, and we don't really know what else might be in a lot of these supplements. And if you take too much, you overload your liver, and it's not a great situation.
Absolutely.
So basically it beats the purpose, longevity.
Yeah, right. I mean, it's interesting because, again, this is part of the co-opting of the phrase longevity. A lot of supplement companies have either moved into, they call themselves longevity supplements now, where people are selling longevity supplements. And as far as I know, absolutely no scientific evidence that any supplement is a longevity supplement in humans.
Yeah, in humans.
So there might be some evidence, for instance, for vitamin D3 in elderly. So that's like if you look at the New Health trial, for instance, then you can reduce certain risks. But even there, the evidence is shaky.
Interesting. So you're not a proponent of recommending vitamin D supplementation. I assume that's on the blood test?
Oh yeah,
but
of course
exactly.
We do. If you have a vitamin D deficiency, especially if it's winter or something, then of course. But then you want to supplement for that. Because then it's pharmacotherapy, to be honest.
We measure,
but not like a blanket statement there again. So don't take vitamin D3 and K2 in a young, active individual who lives in a sunny environment. That doesn't make sense. And then the other question is, what's the optimal concentration for vitamin D?
Where do you guys land on that? I mean, I don't think we don't know the answer, is my view. But what's your target range? So you measure somebody, where are you hoping to see them?
50 nanograms per milliliter.
Yeah, I typically, that's close. I'm 50, 60, somewhere around there. Okay.
And I have to say, people who don't supplement vitamin D3, I have 6 patients who reached that target, and they all come from the Northern Sea. And they just constantly eat fatty fish in their normal diet.
Yeah. Okay. So any supplements that you commonly recommend then? We talked about you view yourself as, first and foremost, you protect people from supplements. I like that, actually. That's a good phrase. But is there anything that you find yourself, aside from vitamin D, commonly recommending?
Omega-3 fatty acids, but we measure the omega-3 index in erythrocytes.
Yeah. And what do you target for omega-3?
12%.
Okay. So I agree with that. That's probably very few people get there without supplementation, I'm guessing. Yeah.
I often recommend magnesium supplementation uh, because the patients typically have a higher sports load.
Okay, so for active people, yeah. I was going to ask, how do you determine who you recommend magnesium for? Is it just based on their activity levels?
Actually, we measure the serum magnesium. It's not the erythrocytes magnesium, but this one is clinically validated. And we recommend it based on their physical activity volume.
Okay.
Mm,
Creatine? Where do you guys land on creatine?
good question. Not we don't suggest it. We don't recommend it to everybody. We assess kidney function first, of course,
And how do you assess kidney function?
with the cystatin C
Okay.
and creatinine. But actually, one of the main reasons we also use cystatin C is because a lot of our patients do take.
Sure. Yeah.
It is more often recommended than other supplements. I sometimes recommend ashwagandha for people who wanna work on that 20% sleep improvement. So they did all their homework on sleep hygiene, and there's still room for a bit of improvement. Sometimes it works, sometimes it doesn't, but I don't recommend it on a continuous regime. Intermittent, see what happens over 6 weeks, for example. Some report better scores in deep sleep. I mean, increase in deep sleep, and some heightened heart rate variability. Some report no effect whatsoever. L-theanine, sometimes exactly for the same sleep architecture optimization, but that's more rarely. Other than that, sometimes calcium alpha ketoglutarate to improve the aerobic threshold, but in combination with aerobic training, of course. I mean, I don't think it does any trick with us sitting on a couch.
Are you convinced that calcium AKG has a beneficial effect in that context? Have you seen enough data that you think that's...
But I've heard data that's in the preprint.
Okay.
Since then, I'm actually recommending to specific patients who actually do a lot of training. But N of 1, tested on myself, it increased my aerobic threshold by around 15%, and that's a lot.
Yeah, interesting. Okay, that's good.
What's your experience with it?
I have never really tried to use it in that context, so I don't have any experience. Yeah.
I think you're the NO1, I think, is a great thing that we should talk about, because we're currently building an NO1 trial platform here as well to actually test things like that.
Right.
So really, like, you're really running your NO1 trial on yourself. It's a randomized trial. It's double blind, should be double blind, and then you can find out what's actually working in a setting. The problem is, what are the endpoints?
Right.
So you really have to define the specific endpoints for each intervention, and that is the challenge that we have to solve right now during developing the platform.
Yeah.
So we might be starting with rapamycin.
Yeah, well, I was going to ask next about prescription medication. So clearly you use anti-diabetics, blood pressure medication, kind of standard approaches when called for by the guidelines. And then I was going to ask, do you do anything with off-label prescriptions for approved drugs, but for other uses? And, rapamycin, SGLT2 inhibitors, Metformin.
So we're the way we approach it, we think about it, is that you basically want to do that in a clinical trial setting. You really want to understand if it's working or not, because we do not have talk about rapamycin. We do not have the strongest evidence in humans. We have overwhelming evidence in virtually any
for longevity
organism.
at least.
For example, longevity,
or
that's
lifespan,
that's right.
Healthspan metrics.
We have some evidence in humans for health benefits, for mental health.
but all more or less anecdotal. Like I totally agree with you. I would love to have the clinical trials, believe me.
True, and that's why I think it's. I mean, I think it's a great drug to test it in a one trial platform. To really,
I'm sure you get people coming in though who are like, I want rapamycin, and what do you do in that situation?
well, I mean, we discuss with them. I mean, it's legal to prescribe the prescribed rapamycin to those patients, but we really have to make sure that they understand what the benefits are and how limited the evidence in humans is, and what the potential downside is. Because I mean, in the end, it's an immunosuppressant. I mean, we don't know the exact dose yet in humans. We know that a higher dose has lots of detrimental. A too high dose has lots of detrimental effects. So that's something we need to make sure before we would think of prescribing it.
Right. Yeah. I mean, it sounds like we align very much on that. I think obviously it's certainly not right for everyone, and it's a very individual situation. And the person needs to be informed about what we do know, what we don't know, what the risks really are, and it's an evolving landscape for sure. What about SGLT2 inhibitors? I'm pretty bullish on SGLT2 inhibitors. I might even, I don't know if I should say this. I might even put those above rapamycin at this point. I mean, partly because we know what to measure, right? You were saying with rapamycin, we don't know how to know for an individual, is it working? Now, if you're doing immune profiling, maybe we can get that signature, but I don't think we have it now. Whereas with the SGLT2 inhibitors, we just measure blood glucose and insulin sensitivity and A1C, and we can tell if it's working or not. Yeah, that's right. And then there are potential benefits on kidney function. Yeah.
Well, I go rarely, but I have to say I go off label there with regarding kidney function. Sometimes I have patients who are chronic kidney disease stage 2, borderline stage 3, and I do prescribe them
Interesting.
low doses of SGLT2 inhibitors without having the German term is popping into my head right now. Without having diabetes.
Right. And when you say low dose, what is considered a low dose?
10 milligrams of empagliflozin.
Yeah, I just recently, well, it's been about 3 or 4 months now, started taking empagliflozin as well. And
what dosage?
10. Yeah. And definitely, based on CGM, my average blood glucose is down probably 10 units or so. A1C, it's only, like I said, only been a couple of months, is down a little bit. We'll see what it is tomorrow. But again, it's nice because there, what to look for. And I was not pre-diabetic, but I was close in terms of at least the fasting glucose A1C sort of definition. My insulin sensitivity has always been pretty good. But for whatever reason, fasting glucose and A1C were a little bit high.
On the CGM, or did you?
No. By real blood test.
Okay.
Yeah, I mean by the clinical blood test.
Because I think that's one of the major problems. People are using CGMs and
Sure.
they don't understand that it's really off, and they are really not that accurate.
Oh my God!
And
I haven't.
A1C is.
I haven't talked about this on the podcast yet, but I actually wore a Stello on one arm and a Lingo on the other arm, and sometimes they were similar, but then they were like this a lot of the time compared to each other. And I'm like, I know my arms are not 20 units different from each other.
At least they should. That's true.
I'm really curious to look at your bilirubin levels tomorrow.
Okay.
Are they
normal
or slightly elevated?
I don't remember actually. I don't think it was outside the reference range.
Because the slower metabolizers, they tend to have longer living erythrocytes, and that falsely elevates the HbA1c.
Yeah. And I also have this dawn effect where my blood glucose, when I don't eat it, fasting, will come up to 104, 105, sometimes even 110 when I first wake up, and then it stays up for a while, and then so it depends on when I get the blood test in that window too. So yeah.
But that's probably determined by your cortisol level, which is rising in the morning.
Right. Yeah. So I'm interested to see what the OGTT shows me. So I came up with the poor man's OGTT, which is you wear a CGM and you eat, I think it's 30 Brock's jelly beans. So you can get the precise amount of glucose
Tastes good.
for breakfast. Oh my God. Eating 30 jelly beans for breakfast, especially if you don't eat a lot of
Okay, then
added
is, I
sugars,
think
it's
it's
like blueberry that's but you know, my glucose would rocket up. But it seemed to come down, you know, by 2 hours. In fact, I would actually go low by 2 hours out from the sort of rebound effect. So.
But to go back to the SGLT2 inhibitors, actually I have this thing I sometimes tell my patients. When I do have an on-label reason to give it to them, I'm actually happy. Because then I can keep them on the SGLT2 inhibitors, like if there's no other contraindication. So if somebody's slightly pre-diabetes, I can start them on SGLT2 inhibitors on label. But the data suggests that it has the cardio.
Cover, that's what you mean?
Yeah.
Right. Yeah. And I mean, I actually, you know, time will tell, but I'm pretty optimistic that the SGLT2 inhibitors as a preventative for diabetes. So when people start to get close to that pre-diabetic range, can really help. I mean, again, it's all context dependent. Hopefully you can get people to also engage with diet and exercise and sleep, you know, but in people who are willing to engage, you can really, I'm guessing, just completely prevent diabetes.
I mean, that's a hypothesis that makes sense, right? I mean, you're just getting rid of the glucose.
Yeah, right. And for people who may not know exactly how these drugs are working, they basically just make you pee more glucose out. So it's a pretty simple mechanism. I don't know if we know why they seem to be beneficial for kidney function from a mechanistic perspective, unless it's just the better glucose metabolism that aids in kidney function. But there also seems to be these additional effects on kidney function from the SGLT2 inhibitors.
Yeah, I would have to speculate on that, because I think it might be the endothelial function that is also glucose dependent. And so if you have if the glucose concentration is too high, then you're going to an endothelial dysfunction. But that would be speculation. I don't know.
The only real downside that I'm aware of, and again, you guys correct me if I'm wrong, is that in some people there seems to be a little bit increased risk of urinary tract infections. Yeah. Do you see that in your patients?
Not in this setting. I used to see it a lot in the
hospital.
In the hospital setting.
Sure. Yeah, and there's probably a dose dependent effect there as well.
And there are also other factors that contribute to that, right? If you're, it's personal hygiene is a very important factor there. Sedentary,
social, economical status.
Exactly. So all these factors
correlates with it.
Okay, where do you guys land on Metformin? Longevity drug?
I used to rank it higher. Now it's not so high anymore.
Would SGLT2 inhibitors be your first go-to over Metformin for diabetes?
Yeah. I mean, it depends. For the therapy, I would decide between GLP-1 agonists, GIP, or SGLT2 inhibitor.
Yeah, I was gonna ask about the GLP-1s next. So yeah, we already talked about that, and you kind of answered. So you kind of, based on the individual, would gravitate to either a GLP-1 GIP combination or a SGLT2 inhibitor. And is that going to be mostly driven by BMI, body weight?
And insulin resistance, because GIP also lowers the insulin resistance. So.
Don't you think a SGLT2 inhibitor will as well? I mean, I don't mean as good as, I mean it also.
I'm not aware of an impact on the insulin resistance. I only know of pioglitazone, like a true insulin sensitizer, and GIP as an indirect effect on lowering it.
I think where I was going was, if with an SGLT2 inhibitor you get the average blood glucose level down, let's say 10 or 15 units over time, wouldn't you expect that to have an insulin sensitizing effect? And again, maybe, I mean, obviously data is what it is. Like, I don't know exactly.
I'm honestly not sure if that would be an insulin sensitizing effect on the end organ where insulin should be working, because it's, I mean, the mechanism for insulin sensitization is working in the organ, right? So you have the bioglitazone and the mitochondrial effect. I don't know if that's really driven by the glucose concentration. I mean, it is, because if you have, of course, I mean, if glucose is high, you get the feedback. The feedback loop is there.
Yep.
But So what I want trying to say is the primary mechanism might not be might be altered in this. So it might not be the exact mechanism. Should probably.
How do the GLPs improve it? What's the mechanism there? Do we know for insulin sensitivity?
The GLP-1, but I don't think I mean, it stimulates insulin production, but in a glucose-dependent fashion. So basically, there is no risk of hypoglycemia as long as the glucose levels are not above a certain level. There will be no insulin secretion driven by GLP. But back to the insulin sensitizing question, I think as long as the muscle is the biggest glucose consumer, and if it's insulin resistant, it tends to be also laid out with fatty deposits, intracellular triglycerides, and I think those are the intracellular drivers of insulin resistance. So the muscle fiber muscle cell is saturated with the triglycerides, and it kind of protects itself from more insulin, from more glucose. Sorry. So basically, without the resistance training stimulus to get rid of the intracellular triglyceride, the cell would still have this tendency to protect itself.
Right.
So even with normal glucose levels out on the other side of the cell, so to speak.
Yeah. And so with GLP-1 agonists, what has been the concern, of course, is that as people are losing weight, they're going to lose a significant amount of lean mass. Is that something that you see? And then what approaches do you take to counteract that?
So I would say the data shows that there is some loss of lean mass, but it's not significantly higher than with any other strategy to lose weight.
Sure. It's anytime you calorically restrict, if you don't maintain protein and do some sort of muscle preserving exercise, you're going to lose lean mass. I would agree with that. It's a caloric restriction effect.
Absolutely. And the other factor, so that's why we also recommend doing exercise with GLP-1 and GLP-GIP agonists, is that the effect, the weight loss effect, is way higher. It's bigger when you combine it with exercise, and it's more sustained.
Right.
So I mean, it's necessary to have some sort of exercise there. You don't have to do exercise to lose weight, but if you want to have a sustained effect, and if you even have a more pronounced effect, you have to combine it, and that's what we recommend.
And exactly, I think this is the point, to inform the patient that the pharmacotherapy is not the sole intervention. It works best combined with a healthy diet in the end. In this case, also higher on protein content, and which is calibrated to the resistance training to counteract for this effect of lean body mass loss.
Right. Okay, so let's shift gears a little bit. You mentioned you do cognitive assessments, and what sorts of approaches do you find effective for people who are, let's say, cognitively suboptimal or at high risk for developing Alzheimer's disease? Actually, we didn't talk about it. I assume you do genetics as well. And so you're going to have people who come in, ApoE4 carriers or homozygotes or have other genetic risk factors for dementia. What are the sort of strategies that you can apply in that context?
So I think there are two major strategies, three maybe, as a preventive tool. So when you're a homozygous ApoE carrier, you want to really control for all the vascular risk factors that are. Lipid metabolism has to be spot on. So that's one approach to that. The other is basically brain jogging. You really have to do exercise, and those even those Sudoku tests that they work. They are a preventive measure. And I think the biggest factor that people don't think of is really community. You really have to be engaged and involved as a preventive measure.
So, by that you mean human interactions, relationships. Yeah, I mean that's the fourth pillar we think about at Optispan. We've got eat, move, sleep. Those are obvious, and then connect and that human relationship component. And so you view this as super important in the context of brain health, which it is, but
Basically,
also
so
overall
anything.
health.
No,
Yeah,
basically anything. So it's really the whole. I think one of the most overlooked factors for health span is this
I agree.
human interaction.
Yeah.
Because we know that social deprivation is fueling
Right.
any sort of aging
Mhm.
related disease.
Right.
So that's should be a rather easy intervention. And
I don't know. I don't know if it is. I mean, I don't know if it's any easier than the others. I think it's hard for especially for people who don't have strong relationships. It's not trivial to go out and make friends for a lot of people, and it takes work, and it's easier sometimes to stay home. And I mean, honestly, in our society today, if you're at all antisocial, it's really easy if you live in a city to never talk to a human being, right? So in some ways, it's much easier to not have relationships today than it ever used to be. Even like micro interactions with people, right? Clerk at the store. No, I can just order it online. So I think it actually takes effort for a lot of people. If you're a very social person, maybe not. But I think for a lot of people, it actually takes a lot of effort. And I'm not sure it's easier. I'm not sure it really is. It's important. It's just as important, but I wouldn't suggest that it's trivially easy. You have to really, some people have to really
absolutely
dedicate effort.
no, I totally agree. I mean that's even part of mental health, that you need to go out there and then there's exercise. You really need to exercise certain approaches to mental health. So I mean that's part of it, but it's very accessible. I mean, at least you don't have that threshold that you hit, it's an economic burden, or it is some sort of a special equipment that you would need. It's really one of the interventions that don't require any infrastructure, but of course it requires training. Sure.
But I sometimes see it in our patients. We also use actually different questionnaires to assess mental health, and isolation is sometimes a signal there. And my strategy is to ask the patient what did they used to do in their youth? I mean, what does youth mean in this context? But when they were 20, for example, what did they used to enjoy?
Right.
And in Berlin, this a big metropolis, you can find then all types of activities and groups of people doing those activities. So I encourage my patients to maybe catch up on that activity again.
Yeah, no, that makes perfect sense.
I don't know, frisbee or whatever it is. And if it's even sports-based, even better.
Yeah, I agree with you. It does get harder as you get older to maintain some of the sports-based community interactions that you had when you were younger. I mean, you can always find a different sport, right? But I played basketball in high school, played football, and I had to give up both of those, really. I mean, I didn't have to, but I knew if I didn't, I was going to get hurt as I got older, right? Especially basketball is really hard as you get older to play competitively, right? So sometimes you have to be willing to change the specific sport that you did and still maintain.
I have the same experience.
So going back to the cognitive stuff and kind of tying this to supplements, where are you guys at with lithium? So as I'm sure you know, a big paper came out. I thought it was a really great paper, suggesting that lithium orotate in particular may play a causal role in Alzheimer's disease. Where are you guys at? Do you recommend lithium for people? Are you on the fence, kind of wait and see where the data comes out?
So exactly. So that's the point. So we at least know from from epidemiological studies from Japan that lithium is also protective against depression.
Lithium in the drinking water. Right?
Exactly, in the drinking water. Yeah, that's right. So it's protective against depression, and we know that because it's a therapeutic as well.
Right.
So I wouldn't come up with a blanket statement here. I think it's one of the things you could consider. And if someone's asking, so what can I take? Can I take lithium as a supplement? I really want to try that. Then we would after informed consent, because you need to take care of your potassium levels again, and these interactions that are important to understand, then yeah, why not?
And I assume in Germany you can get lithium over the counter, or do you?
No, it's prescription.
It's prescription based,
Yeah,
yeah.
it's prescription.
Even the 1 milligram
Yeah.
dosage.
Wow. Okay.
Yeah.
It's
So yeah,
prescription.
in
So
the
that
US,
is
you could just buy
another.
it. You can buy it off Amazon.
Okay.
No, that's another hurdle here, of
Interesting.
course, right? So
Yeah.
that's why we're a little more.
Yeah.
But at least
Reluctant,
it's pharmacy grade, the one
That's true.
we can get
So
in
you're not getting
Germany.
it from a supplement
Yeah.
company. Yeah, that's a good point, actually. Yeah. Okay. Interesting. So we've talked about diagnostics, supplements, prescription medications, approved prescription medications. As I'm sure you know, there are a lot of more experimental therapies, many of which are not approved by the FDA or other regulatory bodies, but that are being used in some of these longevity clinics. So where do you guys land on things like stem cell therapies, exosomes, or even gene therapies, which are, again, I know happening in some clinics? It's illegal in the United States. It still happens, unfortunately, but offshore, a lot of medical tourism. I don't know what the laws are in Germany, but kind of where do you guys land in that spectrum?
So the laws are pretty much the same. So
Same in Germany as in the US.
Exactly.
Okay.
So gene therapy is prohibited. It's a medical therapy. It's a drug that needs to go through the approval process, and it has to be with an indication, and it's even more complicated because you would have to get like a reimbursement plan. You really have to go through the authorities to get cleared for that.
And probably worth saying, gene therapy, I use it sloppily too. That's just a technology.
Exactly.
It's a way
Exactly.
of delivering the intervention. What the specific gene therapy is could be for a rare disease. There are a few cases, at least in the US, that are approved. I assume it's the same in Germany. But what we're talking about in the longevity medicine space, are these unproven, very speculative gene therapies, follistatin being probably the most benign, but people are talking about Clotho and Foxo and SIRT6, which is crazy to me that anybody would think about a SIRT6 gene therapy for longevity, and a whole bunch of other wacky stuff that is happening in clinics. And that's what you're talking about, I'm talking about where that's outside of the regulatory.
It is. It's clearly
illegal in the United States. And
same in Germany. Same in Germany. It's clearly prohibited. And then again, you really don't understand the off-target effects of the vectors. We don't have super highly specific organotropic vectors. In this case, they're probably not even wanted to be organospecific, but we know that liver failure is one of the major risks of gene therapy. And in this case, hyperinflammatory response syndromes. I think it's regulated that strictly for a reason.
So you guys don't do gene?
We don't do.
So no gene therapies for me tomorrow.
No gene therapies for you tomorrow. I'm very sorry. Same goes with stem cell therapies, like general stem cell. People have been doing this for years. So for decades, I should say, basically almost. For cardiovascular disease, we knew that injecting, so that there were quite a few good trials out there, injecting stem cells into the coronaries didn't have any effect. So it's been shown that there's no effect. So we're simply not there yet. I think it's a very interesting technique. It's a very technology is something that is developing.
Right.
And I'm very convinced that there will be a very good use case for that. And we know from cartilage in joints, there are some evidence for mesenchymal stem cells. Right. But we're simply not there yet to recommend it on a broader basis.
And I assume some of your clients ask about it, right? Because again, a lot of the people who are going to come to a YEARS clinic or an Optispan clinic are going to be in this space, have heard about these things. How do you navigate that?
So
I know you say we don't do that, but
so the way we understand ourselves is basically a health companion. Mm-hmm. So we really want to inform the patient, the clients, what works, what's proven to work. What might work given the specific situation, but then have an informed consent that it's still experimental. And really like education of the patient. One of the most important aspects of the job is basically telling patients and clients there's not enough evidence to do that, so stay away from that. Mm-hmm. Same goes for peptides.
Yeah.
Peptides
I was
are
going to ask
very
about peptides as well. I mean, again, peptides, kind of like gene therapy, the phrase gets misused because all peptides are short proteins, right?
I mean,
Short
exactly.
amino acids.
And
GLP-1
some of
agonists,
them
for
we
instance.
use GLP-1.
GLP-1
Those
agonists.
are approved
Exactly.
peptides.
Yeah.
They're bioactive, many of them.
There are many peptides that we've been using in hospital for sick patients, even with pulmonary hypertension, the disease I was working on for many years. So, I mean, they work, but they are highly regulated for a reason,
And they've
because
gone through testing, and
they've gone through testing. You know the dose, you know the response, you know the half-life, you know all these things. And with the peptides, you get over the counter in the States and in the Middle East, I guess.
you can't get them over the counter in the States. So it's an unfortunate gray area that the FDA has chosen not to really regulate. You can buy peptides that are sold for research purposes only, which is why anybody would put a for research purposes only thing in their body. You have to ask, but you can actually do that. So technically that's a way that these companies get around selling these things to consumers, right? Or you can get a doctor to prescribe things like BPC 157 or some of the other, more common peptide, MOTS-C, things like that. Some functional medicine doctors, who now have unfortunately branded themselves as longevity doctors, do that. Then it usually comes from a compounding pharmacy. And I would say it's a gray area, right? I mean, some of these things have been used. BPC 157 is a good example. Been used in functional medicine for 10, 15 years, right? Lots of people have used it. People aren't dying from it. Probably pretty safe. Lots of anecdotal stories that it can have regenerative benefits.
But where's the data?
That's right. So
where's the data?
That's the problem with
Where's
all
the
of
data?
this stuff is we aren't actually getting the data to know what is the frequency of efficacy. Are there certain things about responders? I believe BPC 157, and I've done a little bit of a dive in the primary literature. It looks pretty interesting. Like definitely has bioactive properties and has some regenerative potential. So I believe there are people who respond to BPC 157 and have dramatic improvements in maybe their rate of healing, right? But we don't know anything about side effects. Like how often do side effects happen, right? And so it's just a really unfortunate situation that we aren't getting that data right now. And the regulatory bodies have allowed this sort of Wild West phenomenon to occur, which means we are never going to get the data until that gets cleaned up, right? Until these things are actually appropriately regulated. So it is what it is.
It is what in Germany and in the EU it's different. It's really prohibited to use and prescribe.
Oh, interesting.
Those peptides, because
so it's not common.
It's not common. No, it's illegal to do it.
Interesting.
It's really. I mean, there are a few exemptions in Italy
How
with
does it work?
Thymolysin, for
You
instance.
hear about these clinics in Austria, for example, that people go to get stem cells and all sorts of exotic gene therapies and things like that. Is that just illegal or outside? I mean,
I honestly, you can probably make a case for anything in medicine, but it's certainly a gray area.
Interesting.
It's certainly a gray area.
Yeah. And there's a lot of gray, and I think we have to understand that there's a lot of gray. I guess what would be your advice to people who are intrigued by those kinds of things?
One thing we basically always say is there's no shortcut to a health span.
Mm-hmm.
So you cannot just get an injection or run a fancy treatment.
Sure.
and then live forever.
Yeah, just work the top of the pyramid.
Exactly. You really have to do the hard. You really have to walk the walk.
Yeah.
You really have to do the hard stuff. You really have to change your lifestyle. You really have to do the interventions, and that basically for 95% of the population that we're seeing here.
Yeah.
That's the intervention that would be enough to change their ways. I mean, there might be a very small subfraction of the population who are really self-optimizers and are really adherent to some crazy. I call them crazy, but they're not crazy, but they're very stringent protocols,
Right.
Health protocols that might look into another way to enhance the health, but the question would be why. So we don't know anything if there's an additive effect.
Right. And you might actually offset.
Exactly. That's exactly the point.
Yeah. I agree completely with that. I guess the only thing I would add, coming back to some of these more experimental approaches, is I think for some people the individual situation matters, right? So, for example, if I had an injury that was really, really affecting my quality of life and it was not healing, I might consider BPC 157 in that case, right? Because I would put the personal risk reward in a place. And the first time I ever took rapamycin, that was my situation. I had frozen shoulder. The doc wasn't going to help me. He's like, go home and it might go away in a year. Like, a year? I can't live like this for a year. So I tried rapamycin, right? So I think there are cases where it makes sense for an individual. And I think, as we all get older, somebody at a conference I was at recently, made this comment to me. So he was talking about how much he loves the podcast. And he's like, I generally love your perspective, but I'm 75 and my tolerance for risk is different from your tolerance for risk. So I think that does come into play. I guess the challenge I see is the irresponsible way that some medical providers in this space are just handing this stuff out like candy, right? And so how do we, I don't know how we get to a place where we all feel like this is happening, and other than if we had actually regulation and we could get data on a lot of these.
I think that's the point. So I think there is a way to get comfortable with these interventions, and that's through trials.
Yeah.
So we really have to, and I think that's, for someone who's been in academic medicine for 20 years almost, and who was part of many clinical trials, I think is the only way we have to really understand if A, something is working, and B, what the risk-reward ratio is.
Yeah.
I think empowerment of individuals to take health into their own hands is a major aspect of shifting the healthcare system to something that's proactive, preemptive.
Necessary and a good thing.
But on the other hand, absolutely. But on the other hand, we really need to play by some rules to have solid data. And because science is there for a reason, right? We really want to, it's really a truth-seeking mechanism. It's not just an agglomeration of facts. We really want to understand what's working, what's not. And I think it's also an ethical question in medicine to really recommend things that are working and not do no harm. That's the first principle of medicine.
Is it though? Should it be? Or I guess I would reframe it as, can't doing nothing be harmful?
That's absolutely the same thing. Just waiting and watching and doing nothing could also be harmful. Absolutely. Yeah. So do no harm, I think, is a great principle.
So and this is interesting. I'm interested to hear your perspective on this, because I land more on it should really always be about a rational risk reward analysis. And if the reward significantly outweighs the risk, that's what you should use to make a decision. Now, obviously, we don't always know. It's a guess, right? It's always probabilistic. But rather than do no harm, if the risk of harm, and of course you have to take into account both the quality of the harm and the frequency of the harm, meaning, it's different if you're going to get a urinary tract infection versus you're going to die.
Exactly.
The quality of the harm.
That's exactly the point.
Right? Yeah. So it's not a simple equation, but if you could ever get to a point where you can really do that well, I think that should be the guiding principle for all decisions in life, not just health. What's the relative risk reward? And then, if reward outweighs risk, go one direction. If risk outweighs reward, go a different direction.
But that's basically how medicine's practiced, right? So
I don't think it is.
How it should be. How it should be. How it should be, and how. Maybe I was lucky in my through my years, and how I experienced it. So the basic principle is do no harm. But then again, you always have this risk-reward ratio because I've been working in oncology quite a bit, so you'll always get chemotherapy. Right, so that it's a decision that you're doing all the time.
I think once somebody has a disease, I think that analysis becomes much more prevalent. I think in terms of prevention, it has never been the prevalent way that people think about medicine.
True, but that shouldn't be a problem to shift that to that situation. But of course there are many problems in medicine.
But there is, for example, when do you start a lipid lowering medication?
Yeah, right.
Exactly.
I think,
Yeah, and we didn't actually talk about lipids. So that's probably the other are. Well, probably lipids and hormones you guys deal with a lot, right? So you mentioned, when do you start a lipid lowering therapy? What's your philosophy on that? Are you aggressive? Are you passive? Where do you land?
Passive aggressive. I would say I'm quite aggressive, but really doing a risk-reward ratio, because if somebody's ApoB 100 is like 0.9 and they're 25 and have, or let's not make them 25 but 35, and they don't have any other risk factors, like none whatsoever, they're doing their sports, they're eating really healthy, no blood pressure, perfect glucose levels, I wouldn't start them on a lipid lowering medication. But when the first sign, I mean, I tend to be more aggressive after the age of 40.
Yeah.
Before the age of 40 depends on the context.
And I also think, sorry, don't want to interrupt you, but I think it's also a matter of trajectory.
Yes,
so if you
absolutely.
see, and that's why it's so important to have these regular longitudinal check-ins to get to really see how it's changing over time, so that you can intervene at the right moment. When you see something is shifting off, then you need to intervene, even in that situation when it's turning to the. Because we know, I mean, atherosclerosis is a disease that develops over decades.
Absolutely.
It starts. I mean, it starts in babies, and sometimes, right? If you.
And where do you land on? Because like in my personal case, my lipids. It'll be interesting to see tomorrow. My lipids were never great, but they weren't bad, right? I mean, I was typical, but in the normal range for LDL, at high normal and pretty high HDL. And then over the last year or so, which has corresponded to me going on testosterone, my HDL has dropped. My LDL has been pretty stable. So I feel like I'm probably a candidate for a lipid lowering medication. My ApoB is high normal, at least it typically is. And yet I had a CCTA and my pipes are pretty clean, right? So I don't have existing vascular disease.
Macroscopically.
Exactly. Well, yeah, I mean, again, that's an interesting, I would be interested in your perspective as to whether you believe that a CCTA with contrast, so I got both calcified and soft plaque, is determinative of disease state or not.
I would say it is, but there is also a difficulty in the definition of coronary heart disease in the standard literature. They basically they define it as anything above 50% occlusion.
Yes. Well, I had almost no. I had a little bit of calcified plaque and essentially no soft plaque, but it was certainly less than 10%.
But I mean, if we look at it in a molecular fashion, then it means there are changes there.
There's some disease.
It's really the amount of narrowing that influences the blood flow and also then alters the endothelial function. But this is something that might change over time when the risk factors aren't optimized, right?
So that's the question I'm asking. In your sort of proactive approach, would you, let's just say hypothetically, someone like that, say 10% occlusion in one place.
Yeah, definitely.
Right? You'd put them on a lipid lowering drug right away.
Yes.
Okay.
For sure. Because I also think it is the definition, the standard definition is also based on economical reasons.
Right. Yeah. Absolutely. Like a lot of these decisions in medicine are. So
I can give another. Actually, I'm a clinician. I like to work with hands-on examples. I have this patient. He has a LP little a, which is in the really high range. Has atherosclerosis of the neck vessels. He's 42. Like fished him out of the pond of
He was headed down a path.
He was heading down a path, and I convinced him to take a contrast angiogram of the heart, and it's the widowmaker. The LAD has plaque where it shouldn't have plaque, but the radiologist described it as non-problematic. He's 42.
Yeah, no, that's
it's incipient. It has
That is a classic example of reactive disease care setting somebody up for real trouble.
There I go full aggression.
Yeah. And so statin versus PCSK9 inhibitors.
So basically, definitely PCSK9 inhibitors are the way to go, especially for somebody who has Lp(a), highly elevated for sure. I tend to write a lot of pre-authorization documents for the cost insurance. Yeah.
But I think that's one of the major challenges, right? So we have the data that's population-based, epidemiology data. So we have the data, we have the cutoffs based on this data. but it's really all reactive. And we really
Right.
hardly ever looked into the progression and into the early intervention, the early stages.
Yeah.
And this is really the data that we need to gather, even the whole field.
Yeah, I agree.
So we really need this data.
So where do you guys land on hormone therapy for men and women? Obviously quite different. What's your approach there? I mean, I know you measure hormones, so you're thinking about it. What's your approach there?
Well, it's complicated. It's really complicated. So
Why is it complicated?
well, so we're currently setting up a strategy for female and male health. We haven't implemented it yet as a real standard procedure. The thing is that there are some guidelines how to handle, for instance, female health. If you're
What are the guidelines in
perimenopausal.
Germany?
Well, I mean, the Menopause Society is something that's also important in Germany. The thing is that it's a clinical diagnosis, so there are no hard cutoffs that you could use for perimenopausal interventions,
Right.
which makes it a little harder. So that's from the research aspect. For us, it's quite obvious that we're measuring all the sex hormones to understand what is going on, and then we match this with a cycle, and of course with the symptoms of menopause. But the intervention, on the other hand, is not that much based on the hormonal status.
You mean the measured values in the blood? No, I agree. I mean, that the measured values give information, but it's also very much symptom based, right?
Mm-hmm. Exactly. So
in general, though, I mean, are you recommending hormone therapy for women?
Of course. No, I mean, I think it's very obvious that you have to that you should go for dual hormone therapy, and the benefits, if you look in the literature, seem to outweigh the risks. I mean,
I definitely fall in that camp.
So exactly.
I don't think there should be any question at this point.
But I think there's some historic data that's really scaring people off. Unfortunately, but this I mean, that has been disproven.
I see a shift in the general take on this, because 5 to 7 years ago, I rarely saw women on dual hormonal therapy. Now it's way more frequent.
And by dual hormone, you mean estrogen, progesterone? Yeah. What about testosterone for women?
I've had just 2 patients since the beginning of the year who are on testosterone therapy. Women.
That seems to be, that's something that I just anecdotally from talking to people and some of our clients, it's my perception that that's often overlooked in women's hormone therapy, and it can be really, really important. Obviously, it depends on the individual, but it can actually be quite impactful, especially for muscle function and mood balance as well. So, and then what about for men? Where do you guys? I mean, I've been public that I started testosterone about a year ago. I was clearly primary hypogonadism. It was obvious. I tried lifestyle. I tried boron, I think, because my SHBG was high. Nothing worked, and so then I was like, okay, I'm going to do it. And at least in the U.S., it is very much, in my view, I don't know if overprescribed's the right word, but not prescribed based on symptomology or blood work, but just because somebody wants it sometimes. Like there are docs who just, like I said, give it out like candy. So what's your typical approach when a guy comes in, gets his hormone measured?
I do tend to prescribe it, but it's again a more complex analysis of possible symptomatology, certain assays for sure, and also goals of the person. If they have no symptoms of low testosterone levels, but levels indicative of low testosterone, but they have goals of improving their lean body mass, for example, then I go for it.
Shouldn't everybody have a goal of improving their lean body mass?
They should, but
They should.
they
Yeah,
should.
yeah, they should. But then again, I mean, you know, with the cutoff that we set for interventions, the evidence pyramid, and we want to have level 2 and above. We don't have that much of data there, right? So that we can really recommend it, and so that's why we have this individual.
It has to be right now, yeah. And I think with hormones especially, it is going to be individual, because I'm not sure that the blood measured values are ever going to really always, they're certainly not always going to match the individual symptomology, right? Because I think different people have different sensitivities to these hormones. I'm interested though, philosophically. So, you know,
and again, the longitudinal take is super important. If somebody has normal testosterone levels, but their levels were like, I don't know, 40% higher 5 years ago.
Right. Absolutely. I wish I knew what my hormones were like when I was younger. I just never, it's not typically measured in the United States. So philosophically though, it sounds like you align with kind of where I'm at, and I think where we're at Optispan, which is that for women, perimenopausal, menopausal women, you should start from yes on hormone therapy and then ask for that individual, is there a reason to get to know? Does that fit?
Yeah.
What do you think about men and this question of, you know, I think almost all men, as you go through middle age, 50s, 60s, 70s, there is going to be a decline in testosterone for sure in most men. Should we think about it the same way? Or is that much more nuanced because we don't have menopause in men? I'm just interested in your perspective.
We don't know if we have menopause in men, right?
Well, we don't have the same kind of.
We don't have the same. Of course,
you know, within a 10-year period, every man is going to have this clear cessation in testosterone,
and we don't have the same. Most likely, don't have the same changes that women undergo. But again, I mean that's my easy way to chicken out here.
Well, I ask because, and again, partly for me, this is obviously personal. I've had my own experience, but it's my guess that a majority of men would benefit from some sort of testosterone therapy, at least for quality of life. We have no data on longevity. And in fact, you know, there are some people who will say, well, testosterone accelerates aging. I don't think there's any data to support that other than the eunuch data, which suggests the Korean eunuchs live a little bit longer than intact men. I'm like, if you really believe that data, by all means, go turn yourself into a eunuch. But that does not prove that testosterone accelerates aging. We just don't know. But from a quality of life perspective, I think a lot of men could benefit from appropriate testosterone therapy, not the abusive testosterone therapy that sometimes happens. But I don't know. I mean, I don't know. Is it the case that most men, 80%, 60%, 40%, like it's a question, but I don't think anybody's really having that conversation. It's like people get very polarized on this topic, and I don't think it needs to be.
No, I think but that's true for all the questions in medicine. I mean, we've been discussing all the novel technologies as well that come into the longevity medicine field. There shouldn't be a polarized discussion. It should just
be a discussion.
Focus on, there should be a discussion and focus on generating the data in a way that we can use that. I think that's the most important thing that's lacking in the whole field, the scientific rigor in answering the important questions that are going around. Often I feel that people are just trying to, it's like activism, trying to do stuff and see if it's helping, but we never rule out the placebo effect. It's really not controlled, and we really can't do about it. Just as you mentioned, many functional medicine physicians or doctors doing things, and they say there's anecdotal evidence, and at least even write up the anecdotal evidence that we can start somewhere to see what is happening and then go from there.
Right.
But we need a structured approach to all these questions. I'm 100% convinced.
I agree completely. And I mean, I like what you said there, which is, I think a lot of these docs that use peptides, ubiquitously and recommend stem cells or exosomes or whatever. I mean, I think they generally have good intentions. They're trying to help their patients.
Probably.
But we're not getting, most of them, we're not getting the actual data on these things. And so is it really helping the patients to do that? That's harder question to answer. So let's just finish up and talk about where you see the space going, right? And again, whether we call it longevity medicine or scientific healthspan or healthspan medicine, I mean, what do you see as the real, we've talked about some of the challenges. What do you see as the opportunities going forward? Where do you think the biggest impact can be. Clearly, you're trying to have an impact with what you're doing here and applying some scientific research to it. So, what are you excited about? Where do you see us going?
No, I think honestly, I think it's a societal necessity that something has to change or something is changing. We really need to get away from the pure reparative medicine. I mean, that part needs to improve as well, because there will be disease for the foreseeable foreseeable future.
They're complementary.
Exactly. But we need to raise the awareness that people can take their health into their own hands, and we need to empower them. Yeah. So we need to give them the data and the information.
The only way you can effectively take control of your own health is if you are informed.
That's exactly the point.
Has to go hand in hand.
Exactly the point. So we really need to empower them by information and giving them the data to understand it, and then help them interpret the data.
Yeah.
So that, I think, is something that is changing, and I think that is one of the things that I also see as a major change, that people are really getting to know and really want to know their data. I think one of the other major aspects is really the implementation of AI.
Yeah, that's a big one. Yeah.
So I mean, and this is, I mean, it's basically everywhere. So
are you guys using AI?
We're using it. Yeah, we're using it to structure the data that we generate. We're using AI to do as a medical device to do diagnosis, for instance, for the retinal scan that you experience tomorrow. So it is here already, and it will, I mean, and computers are much faster in running through algorithms than any doctor is, even the best trained doctors.
What about integrating different data types and reporting it back? Where do you land on, because I've done it, maybe you've done it too. You take all of your blood work and you put it in ChatGPT and say, tell me what this means, right?
So I think, I mean, a lot of our patients do that at
Of
clients.
course.
So they come and some of them follow those recommendations religiously, which is a problem because we know hallucination is a huge problem. And
although I would say it's changed a lot. Like the current version of ChatGPT seems to make mistakes a lot less frequently than older versions. But I agree with you. You still want to have a doctor in the loop.
Exactly the point. So it's still the rate is still too high, and it's really inventing lab values, especially with a data set that probably both of our clinic setups have.
Yeah.
It's really inventing data that's not there, just to make sense of the story, and you really have to double check and triple check everything that would come out there. So that's why we're not using it as of yet. But we were trying to solve that problem, and this is solvable. You just have to have some rack systems or some backup systems that cross check. And then this will be a major improvement. And this will also be a major improvement for patients. But now Dr. Google is Dr. OpenAI or Dr. ChatGPT. And we have to figure out what's
and
actually
I'm sure
true.
You get a lot of people coming in with information they've gotten from Google or ChatGPT, and you have to...
I had a patient who actually gave me a 20-page report of a health program that was designed for him by ChatGPT, and he asked me to double check for hallucinations. But not an easy read. Of course. But I think...
well, and you're better equipped to do that than a typical primary care doctor, right? I mean, and you're probably much more likely to actually entertain that person and help them rather as opposed to a typical primary care doctor.
No, but that's a problem, because that actually, I think, drives people away. Primary care doctors are doing a lot of prevention. I mean, that's one of their major jobs, but that's driving patients away from the doctors, because they say, I mean, how should I handle these 20 pages?
Do you guys have the direct-to-consumer blood tests here in Germany? So like in the US, we have all these companies. Function Health is probably the newest, biggest one, where you can go online and buy blood tests, but they don't actually give you any medical care. And then people take these things to their primary care doctors, and their primary care doctors say, get out of my office. I can't, what do you want me to do with this, right? And I agree with you. It's a problem. It's a big problem in the US. Do you have that in Germany? And
we have that. So there are some providers that draw your blood and then integrate that into an app, and then give some non-medical recommendations based on the blood work that they have. It's usually there's not extensive blood work, even if they draw 200 or more parameters. It's not medical advice. It's really...
I mean, that's in my view, that's the problem. I'm all for access to diagnostics, right? Again, when it has no doctor in the loop, though, that's when I think you run into these challenges, and people find things and they don't have anybody to turn to. And if it's something serious, you know, you're stuck, right? So this will evolve, but right now I think it's kind of unfortunate for the general public. I think the three of us, we could go get a direct-to-consumer blood work or direct-to-consumer whole body MRI. That's what I did when I did my whole body MRI. But I've got access. If something's wrong, I have doctors who are friends who will help me, right? The average person maybe doesn't have that. And so
I think it's a major problem for actually bringing evidence-based preventive medicine, healthspan medicine, however you want to call it, out for the broad masses.
Yeah.
Because it's really an access problem. So even our program here is not covered by the general insurance.
Yeah.
It's out of pocket, and you can get reimbursed by your private insurance for at least part of it, and for the core program that we're offering, most of it.
Really? Okay.
Mm-hmm. But it's not accessible for people who have general insurance. And we really need to, but that's a political aspect to the whole story. We really need politicians to chime in to understand that preventive medicine, preemptive medicine is as important, or even more important than the reparative.
The optimistic side of me thinks we will get there, but I think the thing we don't know right now is where is I'm just going to use the phrase 80-20, right? 80% of the benefit for 20% of the cost, or where is the, economic price point where it makes sense from a population perspective to really lean into preventative medicine. There clearly is, that exists. I just don't think we know right now what that is. Like, what would you measure? How often would you measure it? But I think we will get there. I think the one way to look at it is, again, at least in the United States, the current healthcare system is not sustainable.
It is. No,
it's the same thing.
And so, I think we have to go this direction. Hopefully we can do that prior to catastrophic collapse of our existing healthcare system.
Yeah, and that's actually what I'm concerned about, because we have to get the word out that we have to change now, because we cannot wait. I mean, it's for all the players, it's obvious that it's going to crash, and people are just not acting on it.
I would say AI may be the solution here, though. Once it gets to the point where it is good enough that it can really help doctors scale, then it becomes economically feasible and could. Again, I've said this a few times, and I really believe it. I think could help with a lot of the healthcare disparities that are out there right now, because you can allow doctors to see many more patients if they're effectively utilizing these AI-based tools.
Yeah, and those AI-based tools will flag actual medical problems.
That's right.
And they really can be like the guardian for the healthcare system, and really tell people, okay, you need to see this doctor, you need to see this doctor, and you're probably doing fine. What you're doing there, that's fine.
Cool.
So don't.
All right. Let's end on that optimistic note. Anything we haven't touched on that you guys want to talk about? Do you want to tell people where they can find out more about YEARS if they're interested?
Sure. I mean, they can visit our website, years.co. To find out more about YEARS. I think for me, the most important thing is, it's obvious something has to change in healthcare. We really have to move the whole system from reactive to preemptive. And for that, we need data. We need high quality data. We need scientific rigor, and we need the clinical trials. So anecdotal evidence isn't enough anymore. We really need hard facts and hard data. And I think we're all on the same journey to help getting that.
Absolutely. All right. Well, thank you guys so much. And I'm really looking forward. I'll see you tomorrow and report back on my experience getting poked and prodded for 6 to 8 hours. It's going to be fun.
Thanks for having us.
Thanks, guys.
Thank you so much.